Welcome, everybody. We're going to welcome Kelly from Evergreen Hospice, who's going to teach us about hospice and palliative care. And so feel free to ask questions throughout. And I'm going to pass it over to her so she can take away the slides.
Thank you, Misha. Thank you, everybody. And I appreciate this opportunity to talk to you about Samaritan Evergreen Hospice and our Samaritan Palliative Care Services within the Samaritan Health System. This is very informal, so if you have any clients right now that you're working with that you feel could definitely need to have a conversation of hospice or possibly palliative care and some questions just kind of pop up, please feel free to reach out or just start asking questions. Or there might be like a chat box, Misha, if you want to monitor that. So today we are going to understand the concept of hospice, identifying which clients you're working with might possibly need hospice services, and to understand the concept of Samaritan's palliative care program and how it is different from hospice in general. So I just wanted to talk a little bit about our history at Samaritan Evergreen Hospice. We were founded in 1984, and we are a community-based hospice program. We actually had 2 volunteers in the Albany area started our hospice program. In 1986, we became a part of Albany General Hospital, and we became Medicare certified and state licensed in 1991. And then in 2003, we became a part of Lebanon Community Hospital as well. And in 2012, our hospice house was built, and I'll talk a little bit about our hospice house in Albany as well. And then we recently expanded out to the coast, which I'll talk about our service area. So unfortunately, we all have something in common. And that, unfortunately, is we all are going to die. So we can't control whether we will die or not, but we may be able to control what type of care we would like to have, right? So if I were to ask each and every one of you, where would you prefer to die? I would suspect that nearly everybody would say, I want to pass away in my home, pain-free, peacefully, and surrounded by the people we love, right? So I'm assuming this would be your answer. Then your wishes are the same as the majority of the public, everyone out there. But why does this not happen all the time? How can we try our best to achieve these goals for yourself, your loved one, or your clients that you're working with? So I'm just going to talk a little bit about what the hospital means versus hospice. So when you or a client or somebody goes into the hospital, you're really directed towards comfort focused. You go into the hospital for a birth of a child, a broken bone, any type of surgery, heart surgery, appendix, a cancer treatment possibly, preventative medicine, but the expectation is healing, right? You return back to a normal life. So you go into the hospital for a curative focus. For hospice, hospice is directed towards comfort. So there has been a change that has occurred now. There's a terminal illness that is present. Curative measures are no longer effective or desired by the client or the loved one. The client is not expected to survive now beyond the 6-month prognosis. And I'll talk a little bit about the criteria of hospice. The focus is now directed towards comfort care in place of curative care. So hospice and the medical staff are really focused on aggressive symptom management. Hospice is in a private setting, comfortable setting as the patient or client chooses their care. So when a terminal diagnosis is given, it's very, very shocking. It's traumatic. It's paralyzing for the patient and their loved ones. But hospice is here to help you, your loved one, or any of your clients. Our hospice team is committed to their patients. Hospice really becomes part of the family. They're highly skilled at end-of-life care. There's a lot of training that goes into our staff. And the goal is to keep patients pain-free and comfortable. And hospice families meet the needs and help navigate the clients and family through the process of their journey. So I'm just going to talk a little bit about these 4 different modules, if you will. And hospice is directed towards comfort care, but it's also talking about quality of life. So your quality of life might be different than my quality of life. And we have a whole entire team that helps make sure that all of our patients have the best quality of life they can towards the end of life. And our staff really focus on these 4 different modules: physical well-being, psychological, social, and spiritual. So our team meets every week. It's called our interdisciplinary team meetings, where we go through all of our patients and we really talk about all of these 4 domains and how our whole entire team is helping develop that care plan to make sure that our patients are having the best quality of life. And this is our team. So Dr. Emily Looney, she is our medical director that oversees our whole Samaritan Evergreen Hospice. And we have several different nurse practitioners, RN case managers that help manage our patients in the home, in the hospice house, and in the facilities. We have pharmacists on staff, CNAs, social workers, chaplains. We also have music therapy, massage therapy, even occupational and physical therapy for the comfort of our patients. Multiple different volunteers that help in the home and at the hospice house. We do have pet therapy. And then we do have our bereavement counselors that follow the bereaved families for 13 months and after. We are also privileged to be a part of the We Honor Veterans program through the National Hospice Palliative Care. And so that really teaches our team of how to take care of our veterans at end of life. There's 5 different levels of achievement, and we are at level 4 out of our Albany and Newport office. So who qualifies for hospice? So 2 physicians must determine that their patient has about a life expectancy of 6 months or less. Also, those seeking comfort care rather than curative care. So your primary care physician or the hospitalist at the hospital can determine that you do have 6 months or less, or your client does. But if the client and the family don't agree of the philosophy of comfort care, then they're not ready for hospice services yet. So here's our service area. So we have our Albany office in Albany, which is actually out of our hospice house. And if you haven't come visit us at the hospice house, please reach out to me. I would love to show you around and give you a tour of the hospice house. It's pretty amazing. So out of the Albany office, we serve patients wherever they call home in the Lynn, Benton, Marion, and Polk counties. And then we recently expanded in 2019, and we now have an office in Newport where we serve patients wherever they call home in Lincoln and parts of Tillamook counties. We don't serve the very north part of Tillamook County. Adventist Hospice covers that area. But any client or anybody that calls us and we're not able to serve them because of where they live, that's not an issue. We are connected with other hospices in the area that we will make sure that they get the services they need. So I said we take care of patients wherever they call home. So we take care of patients in their primary residence. We take care of patients in assisted living facilities, adult foster homes, nursing homes, and also out of our hospice house. How is hospice paid for? This is a big question that I get asked a lot out in the community. So believe it or not, hospice is 100% covered under Medicare and Medicaid. We take care of all ages. So private insurance has mirrored the Medicare A benefit for hospice. So we take care of all ages. The VA pays as well. We are affiliated with Samaritan Health Services, and we are a nonprofit organization. So we don't turn anybody away if they are appropriate for hospice services. So regardless of ability to pay, we will definitely take care of them. So hospice benefits include, 24-hour access to all of our nurses. We have on-call nurses. We also have our on-call physicians and on-call administrators as well. We are available 24 hours, 7 days a week. If we get a call from our patient and family at 3 a.m., we will talk them through the process over the phone. And if needed, we will definitely make a visit 24 hours a day. All medications that are related to the terminal illness of our patients is covered under hospice services. Any medical supplies or equipment, hospital bed, oxygen, bedside commode, any type of equipment that will make them comfortable in the home, we do cover. And any assistance from any of our disciplines that I listed, we develop a care plan that's designed specific for our patients. So some of our patients might see our nurses 3 times a week, maybe every day, maybe every other day, as well as our social workers or chaplains. It's kind of a revolving care plan. So, and that care plan can change quite a bit, right? As our patient is nearing the end of their life, we might be seeing more visits towards the end of their life, but we are available to assist with any of our disciplines at any time. So I wanted to share the booklet on the right. It's called Gone From My Sight. It's a pretty amazing book that we give to the families when we admit our patients onto hospice, because it teaches them to be the daughter, to be the mom, to be the son, and to know what's happening with their loved one and educating them through the stages of death. So if something were to be happening, how to be the daughter and not just the caregiver at all times. So it's a pretty amazing book. If you haven't seen it, Misha, let me know. I can bring some to your office. And that can be a whole nother education that we can do on the side. So how long can a person stay on hospice? So I mentioned the 6-month prognosis. So generally the idea stems around the 6-month life expectancy, but some of our patients do get admitted and they die within hours, unfortunately. And it's unfortunately because the patients and family don't really get to utilize the full benefit of hospice services. But other patients are on our hospice for weeks, years, and even years, even more than a year or so. As long as a hospice agency can document clearly to Medicare that the patient paints the picture of that 6-month criteria, patients can be on for quite some time. So the benefit periods for hospice. So when a patient gets admitted onto hospice, we have a 90-day, if you will, called an evaluation period, just making sure that the patient does fit that 6-month criteria. And then after that 90 days, we have a second 90-day recertification period. Again, as long as we can paint the picture to Medicare that our patients have the 6-month criteria that they are declining, we can recertify. And then after that second 90-day recertification period, there's the third recertification period of a 60-day, where we have to do a face-to-face visit. So one of our nurse practitioners will go into the home or wherever the patient is residing and do eyes on our patient to be sure that they fit that 6-month criteria. As well as when we have our interdisciplinary team meetings every week, we will go over all of our patients that need to be recertified and talk to Dr. Emily Looney about yes or no, and if yes, these our patients need to be recertified, giving what's painting the picture to Dr. Looney about why we feel our patients should be recertified or why our patients should not be recertified. So after that third recertification period, we go into the unlimited 60-day recertification periods where we're constantly doing face-to-face visits every 60 days to be sure that our patients fit that criteria. Patients and families actually can revoke off hospice, and revoking means take themselves off hospice. So I think the big thing to learn is that your clients, your loved ones, yourself, you are in charge of your health care. If you are not happy with the hospice agency, or if you are wanting to pursue a curative treatment, you can take yourself or take your loved one off hospice service, and that's called revoking. Also, hospice agencies can discharge their patients off hospice or graduate, if you will. So if our patients don't fit that 6-month criteria, of course, we're going to have lots of conversations leading up before that we're going to be discharging or graduating them off hospice services, and then give them other resources out in the community that they can utilize. And then, of course, if their loved one or your client is starting to decline again, just give us a call and we will look into the criteria to see if they fit the 6-month criteria for hospice. So here is our hospice house. And again, if you haven't been here, you definitely need to schedule a tour or just pop in and somebody in the office can show you around. It's pretty amazing. Our hospice house was 100% constructed, covered all by philanthropic funds in the community. So the community came together and made this happen. And in Albany, of all places. Right now, there's we're one of 4 currently built in Oregon, although I think we're still currently just 3, because there was a hospice house up in Portland. Providence Hospice owned that one, but unfortunately they had to close their doors in 2019. But I think I'm hearing rumors that they're going to be opening it back soon. But there's another hospice house down in Eugene, and then another one out in Bend. And then we're lucky to have one in Albany in our area. So we're very fortunate that patients don't have to go to the hospital. That's why we built this hospice house to be as home-like as possible, although we can still take care of patients at this level of care at the hospital. So we built the hospice house to take care of our hospice patients at the highest level of hospice, and that's called short-term inpatient. So short-term inpatient means when our hospice patient has a pain or a symptom that cannot be managed in the home setting. So an example, delirium would probably be one of our top symptoms of if a patient needed to be monitored more regularly to get that pain under control. We will transport our patient to the hospice house, get that pain or symptom managed, and then a lot of teaching with the family, and then transport patient back home is the goal. We also provide respite care up to 5 days for our patients. So if any of our patients' families start to have caregiver breakdown, or they're going to be going on a trip or a vacation in the near future and they need to schedule a time to have a respite stay at the hospice house, we have that opportunity as well. And then we do have short stays. So the hospice house is not a residential care facility. We're actually considered a small specialty hospital. So we don't have 3 meals a day. We don't have activities. It's not like an assisted living facility. It's a very short-term stay at the hospice house. But we do have hospice patients that come, for example, out of our hospital systems or out of our outside hospital systems, and they're newly admitted onto hospice and they have a pain or symptom that needs to be controlled before they get transported home, or wherever home might be. But sometimes home might not be safe, or the facility that they're looking to go to might have a wait list. So we have the opportunity to provide short stays for the families, and that is private pay at this time. And it's a conversation that the hospice staff and the family and patient talk about when we admit our patients to our hospice program. Any questions as I move forward into identifying any clients that might need hospice? Is there anything in the chat, Misha?
Nothing in the chat yet, but if someone has a question, feel free to unmute and ask.
Okay. So identifying your clients needing hospice services. So I'm going to be listing a lot of different things to look at, but I think you know your clients the best, right? You're probably becoming part of the family. Um, you know, you would know more than us for sure, but I'm just going to kind of give you the tools that might stir up some conversation. But no matter what, always feel free to call us at Samaritan Evergreen Hospice to start that conversation with the families, because we're definitely here to help. And it's always good to have the conversation sooner rather than later, because you don't want to have a conversation when it's in a crisis mode, right? You definitely want to get that information out to your clients and families before they go into the crisis mode. So if you're starting to notice any of your clients that you're working with have a decreased oral intake or appetite loss in the last 2 to 3 months, if you're really starting to notice it, that could be a sign. And it could be a majority of a lot of these things that I'm going to be talking about, not necessarily just one thing. But like I said, you know your clients the best, and I think you would know if they're starting to decline a little bit. So any weight loss of 10% or more over the last 6 months that you've noticed. We measure our patients' arm circumference, and that's kind of how we see if they've lost a lot of weight, if you're not able to actually weigh your clients. Any documented change in condition over the past 2 to 3 months that you're noticing, history from the patient and family about a specific decline in condition. Like I said, you might know the families very well and the client very well. Any recurrent infections that are happening over and over. Compromised ambulation or non-ambulatory. A lack of response to any therapies that they might be doing. Increased weakness and fatigue that you're noticing. Any decrease in functional abilities. If you're starting to see a lot of cognitive issues or mental status changes. If they're starting to go into the hospital, into the ER quite a bit, that's a pretty big sign. And we have our palliative care program that I'll be speaking about that will trigger a palliative care consult out of our hospital systems. A desire by the client or the family for curative measures to be withheld. Sometimes your clients and families are already starting to talk and paint the picture of hospice, but they don't want to use the word hospice, you know? So definitely give us a call and we can help you. Any increased calls from the doctor's office, or if your client is requiring more frequent home health visits. Any more frequent night calls from yourself or for home health staff that you're working with. Maybe your client doesn't want to go to the hospital anymore. Maybe they are going to the ER a lot, but now they're saying, I don't want to go to the ER anymore. That's definitely painting the picture for a hospice consult. Patient and family desire curative measures now. Treatment goals are directed towards relief of symptoms rather than the cure of their underlying disease. The caregiver or the family is now becoming more exhausted. You're starting to know or starting to see a lot of changes in the family. And the caregiver is, expressing frustration, anger, and anxious, and just sadness towards what's happening with their loved one. And of course, if you're starting to see the caregiver's physical condition has started to deteriorate, that's definitely something that is definitely give us a call and we can start that conversation. And you can call us directly. You don't have to have the family call us. If you give us a call directly, we can reach out to their primary care physician to get an order to do an evaluation to see if they are appropriate for hospice. That doesn't necessarily mean that we would put them on hospice services, but like I said, just having the conversation sooner rather than later. And if they're not appropriate for hospice yet, they have the tools and the information and education to know when it is time. So we have a hospice video on our website. If you go to our website, samhealth.org/hospice, if you scroll down, there's a play button and it's a 5-minute video that goes over all of our hospice program. And we do touch upon our hospice house as well. But if you're starting to have that conversation, it's a nice video to kind of, introduce them to who we are at Samaritan Evergreen Hospice. And then on the right, the blue book, Misha, I will send some over to you if you don't already have some, but those are really good booklets that I created a while back. Instead of handing a brochure, sometimes I feel like a brochure is so canned and we're talking about a very sensitive, topic. And so this booklet is a really good conversation starter with families. I have put a lot of myths and misconceptions regarding hospice in there. I do talk about our hospice house in the back, but it's just a really good book to have to start the conversation with clients or loved ones that you're working with. Always give us a call at any time. We do have 2 separate numbers that you'll see there, and on the marketing booklets that I give you, our Valley office number is different than our Coast office. So any questions or anything that pop up about hospice? I'm going to start talking about our palliative care program.
I don't have any questions yet. Does anyone else? However, I do look forward to getting the booklet because I think the word hospice in general can be really intimidating. And so just kind of knowing more about it and how to present it sometimes is really great.
Absolutely. Okay, so Samaritan Evergreen or Samaritan Health Services has designed a palliative care program that's separate than our hospice program. So if you were to talk to other hospices in the area, their palliative care program is going to be different than ours. But at Samaritan Health Services, we have designed 2 different service lines, if you will. So we have our Samaritan Evergreen Hospice, and then we have our Samaritan Palliative Care Services. So this is a completely different program that I'm going to be speaking about now. So what is palliative care? The biggest difference, if you were to take anything from today's educational, is the big difference is hospice is a terminal diagnosis and palliative care is not. Palliative care is a separate service line, like I said, than hospice, and we have different teams. It's an interdisciplinary team focused on providing relief from symptoms, pain, stress of a serious illness that your client might have. Again, it is improving the quality of life for the patient and family, but you can pursue curative treatments along having palliative care services in the home. So palliative care services really is just a client that does have a serious illness. It doesn't necessarily have to be terminal. Palliative care is appropriate at any stage of an illness. It could happen where a patient or a client has a serious illness. It could be a temporary serious illness that you would need the team to come into the home to help with. Again, palliative care is provided along the side of curative treatment. We help manage physical, social, emotional, and spiritual needs as well. We facilitate transition into care when appropriate. So our palliative care team would talk about hospice if that were to be the option for them, or any other services out there in the community that we can help them with. So who are we at Samaritan Palliative Services? So we're a specialized team working with you or working with your clients. We provide inpatient consults out of our hospital system. So out of Samaritan Lebanon Community Hospital, we have a team there, and we have a team specific at Samaritan Albany General Hospital, which I'll go into a little bit. And then we have a team over at Good Samaritan Regional Medical Center. And then we also have a team, a separate team that provides home visits. So we have a nurse practitioner, RN, social work, a psychologist, and a chaplain that does go into the home. And we only currently serve patients in Lynn County at this time. And I think that's what a big difference is when talking to other palliative care programs in the area. So who to refer your clients if they need palliative care? I like to ask the question, would I be surprised if this client died in the next year? If you would not be surprised, then consider palliative care. So for our inpatient team, the patients, they really focused on serious life-limiting illness. If the patient is admitted to the ICU with the hospital with a length of stay more than 5 days, or the ICU readmission with same diagnosis in 30 days would generate a palliative care consult. I mentioned this before, but if your clients are coming in and visiting the ED a little bit more often, that'll definitely generate a palliative care consult. But families can also ask for a palliative care consult in the hospital too, if they feel like they need to have that education and their loved one is moving towards a serious illness. Our home-based program, I forgot to change that. We don't just focus on symptomatic heart failure. We actually opened it up to all diagnoses in October of this past year in 2022. So we do take care of clients with any type of a serious illness in Lynn County. So for our inpatient team at Albany General Hospital, our medical director is Dr. Kelsey Turland. Our nurse out of the hospital is Stacy Randolph, and we just added a new nurse, Kathy Hansen. She actually used to be one of our hospice nurses, and now she's with palliative care. Love her dearly. And then our social worker, Molly Gage, she actually was hospice too, and she moved over to our palliative care team. And you're probably familiar with Wes Settlecheck. He is our chaplain out of the Lebanon and Albany Hospital, but he is part of our team as well. Ali Sanchez is the clinic coordinator, and then our manager is Stephanie. And then for our home palliative care team that serve patients in Lynn County, our nurse practitioner is Carrie Batchelor. And then again, Stacy and Kathy are both our nurses out in the field as well, with Molly, our social worker. And then we've got our psychologist. And then we have community chaplain volunteers that help in the community for our patients. Again, Ali is our clinic coordinator, Dr. Turlin is our medical director, and Stephanie is our manager for that team. So I think the sooner you call us, the better we can help. And again, you don't want to wait until your clients go into crisis mode. They might be already talking and painting the picture probably about hospice services or maybe a serious illness and get involved with palliative care. But definitely give us a call. It doesn't hurt to start that conversation. And I think that is it, Misha.
Thank you so much, Kelly. Okay, so I want to open it up for questions a little bit. This is such a great introduction to what hospice is and palliative care, and just allowing us to find community support, I think, that a lot of us may not have known was out there. So thank you for taking your time and sharing all of that with us. But if anybody has any questions, please unmute your mic. And then I'm actually going to ask to unmute for all of you. And then we'll go from there. So I'm going to stop recording now. And this will be available later on our page.